I wanted to just maybe start you off with something cute to look at. That's my children, Katie and Gabe. They don't know it's in here, and one's hiding his face. They now look like this. So, and my patients come in my office, oh, you have little children? Because this is what their pictures are like pretty much in my office. And I forget, no, I'm older. Katie's 17, gonna be a senior. Gabe's turning red, he's 13. He's going to be in 8th grade next year. And my husband, Bob, is an attorney with the DA's office, and he's deer hunting right now in West Texas. So maybe I'll have some fresh meat when he gets home. Now, just brief overview. A lot of people think when people that get to know me, they kind of think, oh, she just does women's health. No, that's a chunk of what I do. What I treat is pelvic health. Okay, and that means men, women, and children. And the anatomy of the pelvis, as we know, we're not little blocks. Everything's connected to each other. The pelvis is in the center of the body. And when I was in PT school a long time ago with Moses, they taught us the pelvis was the central axis of the body. And as little babies, when you start watching them roll and crawl and eventually walk, they use their pelvis to move them a lot. So we need that pelvis and everything around it that connects to it, legs from the ground, upper body and arms from the top, to be working in synergy or together. And if things aren't working so well, it can affect anything. And I'm talking the lumbar spine. We treat lots of that. SI joint, some people have heard that or been diagnosed with sacroiliac joint problems. All of these tie into anything that can affect urinary incontinence, fecal incontinence, or pelvic pain. And then add on top of that any kind of surgeries to any of these areas, especially the abdomen, the back, even the neck. Okay, y'all can still hear me? Okay, great. Let's see. Oh, she's got it all fancy. I have to hit it more than once to get words up there. Okay. I kind of talked about this already. It's just everything comes together there. We've got to all work together to function, to make everything work. And it's where we sit. Okay? My people with tailbone pain, I see lots and lots and lots of tailbone pain. And sometimes tailbone pain isn't just, because the tailbone is acting out. Sometimes that might be coming from the neck. Okay, so that's excuse me, I have to wet the whistle sometimes. Sometimes that's the problem, is we have to be a good detective to figure out what is affecting what, okay? I like to use the example with my patients of a baby tree that if you plant it in the ground and then you stake it bent over with a rope, okay? It's going to grow that direction until you take the pressure off and let it stand back up. Same thing with your bones. We have lots of stuff, and we're going to talk about it, that attach to your bones. Not just the pelvis, but all over. And fascial pull, muscular pull on any of those bones can pull them, change the joint position, cause pain, and go right down the line like a string of dominoes, just knocking each other over. We look at the feet a lot, and this is where I need my 2 volunteers. I did get 2. Every single one of my patients on day 1 of evaluation get to play with my toys here, okay? And I ask them to get one of them for themselves. Now, you girls, maybe come sit here, and I'm gonna let you pick one shoe. I don't care which shoe, take one shoe off. Well, actually, kick both shoes off, because we're gonna measure first. All right. Yep, I'm making it interactive this year, girls. Okay, stand up. Now, you're gonna remember a number. I want you're gonna bend over as far as you can comfortably. Don't throw your back out. Bend over as far as you can, and I'm going to measure how far it is from the floor. Fingers straight, okay? All right. Let's see here. That number would be 5. Same thing. Okay. 5.5. All right. So sit down. I don't care which foot you pick. Just one foot, not 2. The whole time, and for the next couple of minutes, somebody tell me 5 minutes when it's been about 5 minutes, okay? They're gonna roll all over that foot. Roll it, roll it, roll it. Hold my wand, okay? And we'll get back to that. But we were talking about the way things pull on the body and how one thing over here may be affecting something over here, okay? So this is just your pelvis right here, everything. 3 joints. I'm not good at these things. We got 1, 2, 3. 2 SI joints and 1 pubic symphysis joint in the front. Those 3 joints have very, very, very tiny movement, but they need to have movement. We don't want too much movement. We don't want not enough. But they move with your body. Every time you take a step, every time you shift your weight from one side to the other. And if we take away movement from one side, the other 2 joints have to make up for that joint that's not moving. Okay, and on top of it, you have your lumbar spine right there, going up like that, your whole spine. So all of that works in conjunction together. By the way, your slides are not the same. I threw a curveball at Lauren, thank you Lauren, and sent her some extra slides last night. Some of them were to embarrass my kids. Thank you for participating. Okay, here's your spine, sits on top of that pelvis. And I already kind of said this, the sacrum, go back, right there, I hate this thing, this little triangular bone right here, that's the sacrum, with the whole spine sits on top of it. Very, very important little bone. And of course, there's the tailbone sitting at the bottom. Creates a lot of havoc for a lot of people if it's giving them pain or problems. But any stuck motion, if the sacrum is not moving with my other bones of that pelvic ring, can affect walking, standing, sitting, bending, all kind of good things. So that's all orthopedic. So when people say, oh, she treats women's health. Well, yes, I do. Yes, we do. And one of my therapists is here today, Helen Grimes. She's new with us. She's sitting down here supporting us today, but we do a ton of orthopedic because the pelvic floor that so many people are interested in is attached to that pelvis. And the hips involve a lot with that pelvis as well. Anyway, ligaments. Everybody knows what ligaments are, okay? Hold everything. When they're too loose, we lose information because they have little antenna, receptors in those ligaments that tell us where we are in space. Like I know my hand is over here without looking at it because my body has receptors telling my brain where it is. That's why we see in stroke patients, they have a hard time knowing where their body part is, okay? But all kind of things, those ligaments, and this is all in your slides, help us do. Oh, coccyx, tailbone, our friend, we kind of talked about that already. The SI joint. Women have a lot more problems with their SI joint. Number one, because the way our pelvises are different. Men have more narrow pelvises than women. Ours are wider, and actually our hip sockets are not as deep as men, so we have a lot more issues with labral tears or cartilage tears in the pelvis. Has it been 5 minutes for those women? Somebody? 4? Thank you. Okay. Well, y'all better be rolling. Okay. Okay. So women have a lot of issues, especially with childbirth. Our ligaments get more lax during pregnancy, breastfeeding, our menstrual cycles, and so we're more predisposed to injury, and we do stupid things like cheerleading and splits and all that kind of stuff. So anytime we have a female surgery, It puts all of these things, all of our pelvic alignment at risk because of the position we have to be placed in for them to get to us, okay? Fascia. Woo! They're finally doing some studies on fascia. It's been kind of the pink elephant, unmentioned elephant in the room. I'm having these girls roll their plantar fascia. Everybody knows what plantar fasciitis is. Thank you. Okay. Now, y'all can stop. Give me my toys. Okay. And these are just rollers. You can find these. This one I think came from Dick's or Academy. I got this one on Amazon, but they have them in the sporting goods section, but every new patient gets this, okay? So I just had them do 1 foot of their choice. I didn't ask them to do one or the other. So stand back up, and I want to show you how the fascia is one whole sheath. We learn it's from tongue to toes is what we say in school, but it's actually from the top of the head to the bottom of the feet. 12 major fascial trains travel through the body, and they all converge at the bottom of my feet. So plantar fascia may not be coming, the pain may not be coming from your foot. It may be something rotated in my hip or my knee or your pelvis, okay? So I was just making them roll their feet. I don't know what they have. I don't know if they have feet issues. They haven't told me. But hers was 5, right? So straight fingers, bend over just like you did before. And woo! Okay. She is 1 inch from the floor. She was 5, and that was 1 foot. So if you want to roll the other one, it's up to you. All right, Miss. All right, let's see yours. Okay. Yours was 5.5. Mm-hmm. She is 2. So that's not magic, y'all. Everybody should be rolling. And ask my 2 kids. Do I tell them to roll? Roll. And I tell them, I bought one for my husband. He should be rolling. So they don't, but they're told to, okay? But the whole point is, and if you ladies want to sit and roll, go ahead. If y'all want to go back to your seats, go ahead. But fascia doesn't only run on top of it used to be they thought it ran on top of just the muscles, like a stocking. Now they know it's 3D. It goes throughout the organs. It goes throughout the muscles and all that stuff, and it's connected. It comes together, and it makes a tendon. Y'all seen the tendon on chicken? When you eat chicken? That's just fascia coming together, becoming a tendon and attaching to a bone. There are now studies out there showing that it also conducts voltage. So think about when you're cut, like women with C-sections or what have you. We've lost some voltage that's going across there. We need the voltage. Our body runs by voltage. Think about when our heart stops. Okay, so scar tissue manipulation we work with a lot as well. Adhered scars are super important to get them moving again, okay? So, let's see. Oh, fascia can withstand up to 2,000 pounds per square inch of force before damaging it. We can stretch it, but we can't break it. So when we're working in the clinic on you, we're trying to move some fascia. We've learned what we call some decompression techniques, some taping, some hands-on methods, but we're never gonna break your fascia. I'm not that strong. And I know Helen's not, and Mary Lynn is our PTA. But we can manipulate it. We've been taught clinical ways. These 2 just manipulated theirs with the little ball rolling their feet, okay? And my patients, I tell them 5 minutes per foot per day. So if you're sitting at a desk or watch, and when you do it in standing, you can get a lot more pressure, but you can also do it in sitting. Let's see. Ha! Anybody want to name those? Go, Helen. Go. No, but that white stuff that's not bone, that's fascia coming together as tendons and connective tissue, okay? And all of these guys need to like each other. Okay, pain. Consider pain your friend. They're doing a lot of research, thank the good Lord. They're doing a lot of research now on pain and different ways it should be approached from the patient standpoint and from the practitioner standpoint. There are a lot of things you're going to probably hear or read call about neuroplasticity of the brain. And we try to change the way, like if I want a movement in my patient to change, let's say the way they squat, okay? I don't want the knees caving in, which is real common, and that's coming from up above or maybe down below. But we got to figure out why their knees cave in when they do a squat. So once we get them all straightened out, research shows 14 consecutive days, 30 times a day, doing the corrected motion will change the brain map in your brain, neuroplasticity. It will change the way, because your brain's telling you right now to do that, okay? This is the way you squat, okay? Well, we get you all straightened out, lined up, get you in a mirror, show you the right way. Your homework's going to be 2 weeks, 14 consecutive days, 30 times a day in a mirror. Do that. And that brain is going to learn a new way of doing it. That's research. I didn't make it up, I promise. Okay, so pain is your body's way of saying, something's got to change, okay? Something wrong, something's got to change. Let's change it. Don't just live with it, okay? Don't push through it. No pain, no gain is not really a good motto, okay? I gotta get used to this pointer thing. These are all, everybody knows what causes pain. A lot of them is stretch injury as well. People don't realize we can injure ourselves by overstretching nerves, overstretching ligaments. Think of a sprained ankle that's been sprained over and over and over again. Now we have what we call weak ankles. Well, it's overstretched ligaments, but we got to retrain the muscles and the other parts of the body around it to kind of step up, okay? Entrapment. Scar tissue is not the only thing that can trap nerves. Muscles can trap nerves if they're overactive, too stimulated. So we have to figure out if something's too stimulated and bring it down, or what we call inhibit it and deactivate it. And then in a muscle movement pattern, so if I'm handing something to you, that's going to take many muscles to do that, to work in concert together. But if one of them is overactive, it's going to prevent me from doing that. So I got to figure out why, and then help you get the pattern better and activate other muscles to wake up and do the job. One of my patients had pain at the fibular head, which is right here. There's a little bone on the outside of your thigh, the lower leg. Pain at the fibular head. She was a very recreational athlete, did a little bit too much sometimes, but that was her pain, was right there. Well, after doing our detective work, it was a muscle called the QL, quadratus lumborum, which is in your low back, that was not activating enough and doing its job, so somebody else has to come in and do it. So her side of her hip and her IT band, which the IT band attaches to the fibular head, was overactive because the quadratus lumborum was underactive. And the root of the issue is why. It was a biomechanical problem. It was a joint positional problem. She had other issues that she was seeing us for, but that was something that bothered her every day, and it bugged her and bugged her. So that's just an example of that right there. Okay. Okay. Those are still a mystery to a lot of people, even doctors. But we're getting some good results on Helen. But just getting things lined up and getting things working better gets pressure off of nerves, pressure off of things. A lot of times that's a nerve irritation problem we have found. Okay, sometimes it's a hormonal problem. Sometimes it's both. Interstitial cystitis, they've now changed that to PAB. No. Painful bladder syndrome, PBS. It's not a station, only a TV station now. Okay, overactive bladder and incontinence. I know there's lots of medications for both of those, but that's pretty much putting a Band-Aid on a symptom, not getting to the cause of the symptom, which sometimes overactive bladder is a diet, taking in too many irritants. Sometimes it's entrapped by old scar tissue if we've had some surgery in this area, and the bladder can't expand and fill up as much as it should, and empty and all that good stuff. So if we release it, it can not be as agitated, is what I'm getting at, and it can expand and deflate every time we go to the restroom. Pudendal neuralgia, another biggie. That's just the pudendal area is anywhere that touches a horse if you're riding a saddle. I mean, touches a saddle if you're riding a horse, sorry. My brother did that to me growing up. He'd mix words backwards, and I still do it all the time. So anyway, pudendal neuralgia is big problem. Sometimes missed, sometimes misdiagnosed. It's something else, but lots more research being done on that, thankfully, and patients are getting better treatment there. And there's our friend. Lots and lots of tailbone pain out there. Okay. Now, everybody that comes into our clinic on day one, they get the ball treatment, and they get taught how to breathe. So you guys get to do this one. Okay, so I want you to take a breath, a big old breath, and tell me, is it in my chest? Or did my belly move and my ribs move? You don't have to tell me, just think it in your head. Did your shoulders lift up when you took that breath in? They're not supposed to. Did your neck get tight when you took your breath? Not supposed to. When you go to bed tonight, put one hand on your chest, one hand on your belly, lay there like you're going to sleep. Which hand rises and falls the most? This one or this one? It should be down here. Go back in time to your children, or if you have grandchildren, watch them take a nap, like age 2 and under, okay? Watch them take a nap. Their chest isn't moving. It's all here. It's their belly, and it's their rib cages. That's the way we're supposed to breathe, is our diaphragm and our abdominals. And when we start becoming chest breathers for one reason or another, especially our smokers, they have a really hard time with this one, that we now are upregulating what we call in the clinic, upregulating your sympathetic nervous system, which means you're anxious, okay, and most chest breathers are, okay, and we have to teach them stop that. So if I'm a pain patient and I've had pain for a long time, and I'm a chest breather, a pain level of 4 is actually going to feel to me like a 7. So they may get a little agitated on day 1. Wait, you're making me roll my feet and you're making me breathe. Yeah. Okay. Because diaphragmatic breathing and abdominal breathing is the way we are meant to breathe. And if we don't use this abdominal cavity correctly, we're actually going to stress my pelvic floor even more, and all our work is for nothing. If you're coming in to see me for pelvic floor pain, coming in to see me because I'm leaking, tailbone pain, SI pain, if you are not using this canister like you're supposed to, that pelvic floor and everything that's around it is not being used synergistically like it's supposed to with the upper half. We're not cutting slices. We're one piece. We're one organ, our whole body. So it has to work together. Rib cage has to be over pelvis, and this works together synergistically. But if I'm doing this all day long, number one, you're gonna get some neck pain too, okay? And my upper chest breathers always have neck problems, always. And they always have that little catch behind my shoulder blade, especially on the right. We call that T4 syndrome. That's a whole nother thing. But that has to do with diaphragmatic breathing, and it's not, you don't need You don't need to go get chiropractic adjustment, but it's about your diaphragm and breathing correctly. And we call this the pelvic canister or the abdominal canister. If I'm only using this, if I'm only using from here up to do all the work, then the pressure from here to here, I want you to imagine a Coke can in here, okay? It actually gets compressed. Like, see, I know you can't see it, I want a bigger one. See the bug eyes? You see that? The bug eyes? And then every time, so there's more and more pressure in here. You got too much pressure in here. So every time I stand up or sit down or get in my car or, God forbid, go for a walk or go for a run or exercise, I'm doing this pressure on my pelvic floor, 20,000 times a day, okay? Actually, they did a research study. Our diaphragm moves 20,000 times a day, making us breathe. But think of a pregnant woman who has no room to do this. We call that pistoning, okay? Pistoning of the diaphragm. She gets a pass on proper diaphragmatic breathing for a little while. But that's where women start usually becoming chest breathers, and they don't go back to what they're supposed to be doing in breathing with their diaphragm and their abs. They start sucking it in, wearing Spanx. Well, guess what? You just made that pressure worse. My eyes are bugging out more. You just made it worse. Well, why do I leak more? Well, let your belly go and breathe, okay? Because they're just making that canister even more tight, okay? And if it's painful down there, more pain. And the pelvic floor is a wimpy, puny little thing. It cannot compete against your diaphragm and all this pressure. It's gonna blow, girls and boys. It's gonna blow at one point or another, okay? So, yes, breathing, number one. Movement, number one. Number 2.5, but yeah, we start all this. If all that moves when you're diaphragmatic breathing is your belly, you're doing it wrong. We kind of talked about that, okay? So you should feel the side of my ribs expand like butterfly wings, and you should feel the belly go out. And women do not like that feeling, especially on the beach in a bathing suit. But that's how we breathe. Okay, so that's a proper breath. Nothing moving up here, none of this business. That hurts. That's bad, okay? Here's all the stuff we do. We're gonna evaluate you on day one. And it's gonna take a while because there's a lot of moving parts that we gotta look at. Basically, it boils down to treat what's tight, let it go. Look at the posture. A lot of postural restoration is involved in this because it's all biomechanical, one-piece person. I don't have an arm doing this over here and a leg over there and a knee down there and a foot over there, okay? It's all connected. Strengthen what's weak, okay? Because if it's weak, it's not helping you at all. But it might be, it may not truly, here's the mystery. May not be weak if something's stuck. When we let something that's stuck go, the strength may be there. We just don't know because it's not had a chance to move in God knows how long, okay? Restore breathing, improve flexibility. Those ladies just gained inches on the toe touch test, which everybody would say in the past, I gotta go stretch my hamstrings, okay? They didn't stretch their hamstrings. They released their plantar fascia with a ball on one foot. I want both treated at home, but that was just an example. It wasn't their hamstrings. That was their nervous system saying, halt, something is stuck somewhere. So undo it, and then I'll take the brakes off. It was a protective mechanism. I know you're all looking at me like a calf staring at a new gate, but trust me, okay? There's more release. Oh, we release. Improve firing of cross stabilization. The body works in an X. I can always find pain in an X, okay? They'll come in and they'll say, oh, it hurts right there. But then I start checking on other stuff. Oh, but it hurts right here too. There's my X, okay? The body has to crisscross protect itself because we're not one-sided people. We are two-sided, and we work reciprocally together, and that's the way the body protects itself and works best. And we do tons of education, huh, Helen? Tons of education. Frequently asked questions. Adhesions. Now, there's lots and lots and lots and lots of examples of adhesions. There's endometriosis adhesions. There's adhesions from molds, broken bones, and surgical adhesions, and what have you. So we kind of figure out what's not moving well, what's keeping it stuck, and try to get it moving again, okay? And we do that through all kind of different things. I need to update that. There's some more things that we do. What kind of things do you do to reduce or relieve pain? Well, that's a big pain reliever, is number one. Releasing a lot of adhesions is a big pain reliever. But we use what we call modalities if we need to in the clinic. And that is not going to fix the problem. That's just going to make you a little more comfortable, okay? How do you help strengthen the pelvic muscles? Well, there's the big biofeedback. Everybody's wanting biofeedback. We do use it. I don't use it near as much as I used to when I was a new pelvic therapist. I've been doing this about 17 years now, maybe, I think. Something like that. But we use all kind of other instruments, mainly our hands, okay, to teach what needs to be taught. When we need to, we break out the biofeedback. Kegels are not for everyone. If I could make a big slide, they are not for everyone. Just because you're leaking urine does not mean you're weak. Remember that thing I told you about earlier? If something is stuck, it may be appearing as a weakness, but it's not a true weakness. It's they can't move because they're being restricted from movement. And on top of it, if we have what we call a spastic pelvic floor or a short pelvic floor, don't worry about that. That's another whole issue, whole talk on that I can do. Those women or men that have too much tone in their pelvic floor should not be kegling, even if they're leaking, because you're going to make the spasms worse and the pain worse and the leakage worse. If you've ever woken up with a crick in your neck, which most of you probably have, that's a big old spasm in your neck. Can't turn that way, can't move your neck. If you walked into my clinic that day and you have that going on, I'm not going to put a 20-pound weight in your hand on that side and say, let's go. That's what women with spastic pelvic floors, and men, when their doctor says Kegel, you're just making it worse. So they're not for everyone. And I've actually had to explain that to a couple of practitioners. They thought I was crazy telling this woman who's leaking, not Kegel, for now. That may come later, but we have to knock out some things first. I'm really passionate about that. Okay, let's see. How long does it take? Everybody's different. May take 3 visits, may take 5 visits, may take 10 visits, may take 15 visits. Depends on how many bowling pins we need to knock down and how compliant you are with the home program we give you. Because we usually see patients once a week, because that's the only slots we can get you in. There's 3 of us. There's a bunch of y'all. So we teach you a lot of things to do at home, because you have 6 days out of the week I'm not with you, or Helen's not with you, or Mary Lynn's not with you. So we teach you and give you lots of good tips. Is it hard? No. Is it hard, Helen? No. Okay. We try to make it easy, right? I usually have to have it dumbed down for me. All right. Do you help with urine or bowel leakage or incontinence? Yes. Unless it is a surgical intervention that's required. And occasionally there are times. But I always try to encourage the conservative line first before surgery, because that's just more, there's going to be some more scar tissue and some more problems after the surgery. But if we can fix it or help with it prior to and give it a try. They do it with the professional athletes. They tear an ACL in football, NFL, they're going to go to therapy for 6 weeks before surgery. They're going to have their surgery, and then they're going to bookend it with 6 more weeks of therapy after surgery, because research shows, and that applies to women with pelvic organ prolapse, research shows they do 83% better if you book in therapy rather than just surgery alone. And that goes for any injury, but it also applies to women. They did a study for women with pelvic organ prolapse and physical therapy intervention, okay? So, you deserve better than a guess. And sometimes that's what you may feel like you're getting, or you're reading too much on the internet and you're not getting enough information from your practitioner or your mom or your sister or whatever, you know, because the things we talk about in the clinic, sometimes we don't want to talk about with mom, friend, or sometimes even our spouse. But I do highly, I'm very passionate about this as well. If you're going to go see a pelvic floor therapist, because I know there are other places in town that advertise it, ask for their certification. There's only 2 bodies that certify people for pelvic health practitioners. 2 institutions, Herman & Wallace and the APTA. And if they don't have it, ask them about their study. Are they research-based? How much experience have they had? Because there has been harm done because they're trying, they don't know, okay? I am only research-based, and that's why I picked Herman & Wallace. And we have a PRPC behind our name. I'm the only PRPC in the state. There are other certified pelvic floor therapists in the state through the APTA, which they'll have WCS behind their name. But I think the closest one is Lafayette. And on the west side is Houston. There's nowhere between Lake Charles and Houston. And I get a lot of Texas patients, a lot. And I get to meet a lot of Texas people. So I enjoy it, I love it, but I want you to ask questions. Ask them questions. And that does involve the SI joint, and it does involve the lumbar spine, and it does involve the hip, and it does involve the pelvic floor. They all work together. So I just want you to be a smart patient and ask lots of questions, okay? Because you do deserve better than a guess. And there's my ending on a happy note. That's my puppy Happy. His name's Happy. He's asleep. He sleeps next to me. And everybody deserves a comfortable place to sit. And that's for my tailbone patients. They really need that. And you guys should have this in your handout if you need to contact us. If you want to send all we need is a doctor's prescription for physical therapy with a diagnosis, and that can be faxed or you can call, doesn't matter, and we'll get your ball rolling and get you in as soon as we can. So thank you. Do you have any questions?